Hello, and thank you for joining our October webinar. My name is Ellen Johnston, Program Manager of Risk and Coding Accuracy at Mount Carmel Health Partners, and I will be your host for today's webinar. We are excited to dive into this month's topic, substance abuse disorder. But first, I'd like to cover some details. Health Partners is providing a small incentive for your time and attention today. In order to receive your payment, we ask that you watch this presentation in its entirety by December 25th, 2020, fill out the webinar attestation and W-9, and return to Health Partners no later than December 25th. If you have questions throughout today's presentation, please feel free to contact myself or Dr. Bennett through our contact information listed at the end of the presentation. Now, let's get started. Our webinar topic today is focused on substance use disorder. Our featured speaker today will be Dr. Paul Bennett. Dr. Bennett is a physician liaison with Health Partners and board certified in family medicine. He retired from his practice in Grove City in 2018 after 12 years. Prior to that, he was a primary care physician in Southern California for 24 years. He was in practice with a strong managed care focus with risk contracts. Welcome, Dr. Bennett.
Thank you, Ellen. It's a pleasure to be here to discuss this topic with you today. Before we start discussing today's topic, let's review some of the risk adjustment essentials. Feel free to fast forward the video presentation if you feel competent in your basic risk adjustment knowledge. Risk adjustment is the methodology by which CMS determines how to adequately allocate resources to Medicare Advantage plans for patient care. There are many factors that determine resource allocation, both demographic and clinical. Demographic examples include patient age, patient gender, institutional status, Medicaid status, and the reason for being Medicare eligible. Clinical factors include chronic conditions and diagnoses that have been shown in CMS data to require more resources. As you know, there are approximately 70,000 diagnosis codes included in ICD-10-CM. Every year, each code is evaluated using CMS data to determine which codes utilize the most resources. Once that is done, the data is normalized so that the average Medicare Advantage patient has a risk score of 1.0. Around 9,500 diagnosis codes are determined to affect risk, and they each map to what is called a hierarchical condition category, or an HCC. An HCC is a group of chronic conditions that are clinically similar and have been determined to have a similar effect on resource utilization. Each HCC has a weight, and these weights are what calculate the clinical portion of a patient's risk score. There are 86 HCCs that are included in the 2020 risk adjustment model. For a diagnosis code to be captured on the claim, it must have supporting documentation within the record. An easy way to remember documentation requirements is the acronym MEAT, M-E-A-T, which stands for monitor, evaluate, assess, and treat. Only one of these elements needs to be present for each diagnosis that is taken into medical decision-making during the visit. As telehealth is becoming more frequently used, the Medicare Advantage population due to COVID-19, it is important to note which modes of telehealth communication are acceptable for risk adjustment and for closing HCC gaps. In order for telehealth visit to be eligible for risk adjustment, the visit must take place with real-time audio and video capabilities by an approved provider for risk adjustment, such as an MD, DO, PA, or CNP. Most importantly, it must be documented in the medical record that the visit was completed over telehealth with synchronous or real-time audio and video services used. Documenting this and the time of the visit in the medical record will keep the visit compliant with CMS when capturing and closing HCC gaps throughout the year. Next, we will jump into information specific to substance use disorder. The term substance use disorder can be broad, but it mainly refers to harmful or hazardous use of psychoactive substances such as alcohol or illicit drugs. More than 700,000 Americans have died of overdoses between 1999 and 2017, which is a harrowing statistic about the dangers of substance abuse. About 21 million Americans have an addiction to substance, but only about 10% of them have received treatment. Not only is substance use a danger to the health of the American population, but it costs the U.S. $600 billion annually. ICD-10 has 3 tiers for choosing a diagnosis: use, abuse, or dependence. Use is defined as the use of a substance in a social setting to feel the effects of the substance. Abuse is defined as a pattern of use that can cause problems at home or work and lead to unsafe decision-making. Dependence is defined as substance use such that it can't be controlled by the individual, and when a stoppage is attempted, withdrawal symptoms are experienced. Dependence is the most severe, followed by abuse, and use being the least severe. Although always up to the provider's clinical judgment, abuse typically is when the severity of condition is mild and the patient is experiencing 2 to 3 diagnostic symptoms. Dependence is considered when the symptoms are either moderate or severe and the patient is experiencing at least 4 of the diagnostic symptoms. On the right is a table outlining this for opioid use. These suggestions for code capture and more reading for the DSM-5 criteria can be found at the source at the bottom of this slide and on the worksheet on slide 11. This slide outlines some diagnostic criteria that can indicate a person is having a substance abuse problem. 2 of the following must occur in a 12-month period: hazardous use, social and interpersonal problems, neglecting major life roles, withdrawal symptoms, use of larger amounts for longer periods of time, or any signs of tolerance to the substance. On the previous slide, the differences between use, abuse, and dependence in ICD-10 were discussed. It is always important to be as accurate as possible when documenting the patient's condition. If 2 of these conflicting terms are used to describe the patient's condition, the most severe term will be chosen for coding purposes per ICD-10 coding guidelines. For example, if use and abuse are documented together, a coder or health plan will code for abuse. If dependence is documented with use or abuse, a coder or health plan will code for dependence, since it is the most severe of the 3 diagnoses. There are 3 HCC categories that include substance abuse diagnoses: HCC 54, 55, and 56. These will be explained in detail in the following slides. There are 431 diagnosis codes that map to one of these 3 HCCs. Noted on this slide, alcohol and drug dependencies and most drug abuse diagnosis codes are risk adjustable, but the diagnosis of alcohol or drug use does not risk adjust unless there are related physical complications or psychological symptoms. As always, the code selection should be based on what is most accurate for the patient and the patient's current status, not on the basis of risk adjustment. HCC 54 maps to diagnoses that include substance abuse with psychotic complications. For example, F10.231, alcohol dependence with withdrawal delirium. You can see on this slide some of the more frequently used ICD-10 diagnosis codes listed. There are 108 diagnosis codes in this HCC. HCC 55 includes substance use abuse disorders, moderate or severe, or substance abuse with complications. This category includes intoxication, dependence uncomplicated, in remission, or with withdrawal. Shown on the slide are alcohol, opioid, cannabis, and other sedatives. HCC 56 includes mild substance use disorder or substances other than alcohol and cannabis. It is best practice to still document the level of severity of substance use disorder, even when that disorder is historical. Substances included in this HCC include amphetamine, opioids, cocaine, and hallucinogens. When documenting the patient's condition, a few important things to keep in mind include type of substance. What is the patient struggling with? Any details about the pattern of use? Any mood or psychotic disorders related to substance use? Any withdrawal symptoms present? And finally, is the patient's substance use in remission? The box on the left shows each ICD-10 category code and what substance corresponds to each category. This can be helpful when trying to select a code for the patient. Now we will review some documentation scenarios that will just demonstrate some of the material we covered today. I'll turn it over to Ellen now.
Our first example is a 75-year-old female who suffered from a fracture of her right fibular shaft. She was treated with a walking cast and responded well. However, she still continues to complain of pain and demands refills of Norco. Workup reveals a well-healed fracture. Later, the provider gets a call from the local pharmacy that she tried to fill a prescription for the same drug from another provider. The provider documents she has an inability to cut back on opioid use and is seeking to increase her medications illicitly, and diagnoses her with opioid abuse disorder moderate. The appropriate ICD-10 code for this scenario would be F11.20, opioid dependence uncomplicated. Our second example is a 65-year-old male who is a successful contractor. He returns to the office after elevated LFTs are found on a routine physical. He admits to drinking daily but says it's no big deal to him. Later, he admits to sleep disturbance and uses 2 drinks at night to fall asleep. The provider documents the patient has alcohol abuse disorder with alcohol-induced sleep disorder. The correct diagnosis code to use would be F10.182, alcohol abuse with alcohol-induced sleep disorder. The last example is a 67-year-old male who drinks between 6 and 12 beers over the weekend. He doesn't think it's a problem, but admits his wife doesn't like it when he gets intoxicated. The provider diagnoses the patient with alcohol use disorder with intoxication since he regularly drinks and experiences the discomfort of his loved ones about his drinking. The correct diagnosis code to report in this scenario is F10.920, alcohol use unspecified with intoxication uncomplicated.
To summarize our content today, we have 3 important takeaways for review. Number 1, when a patient is using a substance, make sure there is clear documentation of what substance they are using and the pattern of use. Number 2, if the patient has experienced complications from substance use, document those as well. Complications can include physical, such as sleep disorders or hallucinations, emotional, such as problems at work or with family, and psychological, such as anxiety disorders or other mood disorders. Lastly, document if the patient is in remission, or if they are experiencing withdrawal symptoms related to their substance use. Our last webinar for the year will review guidance on acute conditions misdiagnosed in the outpatient setting. This will conclude our yearly series. There will be no webinar released in the month of December. Below are the references that were used for the information presented. Thank you for attending and listening to our presentation today. Please return the attestation document and W-9 included in the email to Ellen Johnson by December 25th, 2020, if you are interested in the incentive. If you have any questions about the content, please feel free to reach out to any of the contacts listed on this slide. We hope you learned a little bit more about substance use disorder and are able to apply this knowledge in your everyday practice.